right, I just have a few minutes left. I'm going to talk about Amivantamab plus Lazertinib versus osimertinib. This is that third option I mentioned. It's the Mariposa clinical trial. And I'm going to focus in on the blue box and the gray box. That's the combination versus osimertinib again is the control, so to speak, the standard arm alone here in this study. Otherwise, very similar to the last trial that I showed you. And then just Amivantamab's a little different from the stuff we've talked about so far. This little picture on the right shows, in some sense, the structure. It's an antibody which binds to EGFR and to MET, which is a different sort of cell surface marker that sits on the surface of many cancer cells. So it binds to both of them at the same time. And we know that MET is also important, likely in cancer signaling and in EGFR inhibitor resistance. Here's the outcomes from Mariposa. Again, better progression-free survival from 16 to just shy of 24 months with combination therapy compared to the pill therapy alone, so the blue line versus the gray line. And again, currently no significant difference in overall survival, though just like on the last graph I showed you, it's kind of trending that direction. People on average seem to be doing a little bit better with the combination versus the pill alone. Again, going along with the idea that upfront intensive combination therapy with these sort of regimens may gain a little bit of benefit in terms of long-term survival. I think we won't be surprised if it does, but at the cost of some of the side effects that I've been talking about when you start those sort of more intensive therapies up front. I think the Mariposa side effects are one of the reasons why I think a lot of us aren't reaching for this first just yet. It's an EGFR MET antibody. So you see both the classic EGFR side effects like skin rash or the ingrown fingernails. You see some MET-related side effects, which we haven't talked about, but a classic one, if you would target MET in cancer cells, is what's called edema, like swelling in the ankles or kind of lower legs. So something you watch for on this drug. And there's a couple kind of special side effects that go along with this particular drug, including risk of what are called infusion reactions on the first couple doses. And these are a lot like, almost feel like an allergic reaction. So something that your doctors need to be aware of and ready to manage, and that you should be aware of if you're getting it, so you know that what's happening is actually something we kind of expect. It happens in about 2/3 of people, but just needs to be treated. And people who get this combination have an increased risk of blood clots. So there are some preventative blood thinners that people should take in their initial months of treatment to reduce risk. It's a little more complicated, I think, and I think some of those skin side effects are a little more significant than some of the other combinations that we've seen thus far. So for me, I don't usually recommend this first, but it's certainly something I'd bring up with patients. Here you can look at the same sort of high risk, low risk subgroups, and same thing as before for some of these high risk situations like having brain metastases or detectable EGFR in the blood. Certainly there's a little greater benefit to getting combination therapy potentially. So one slide on the uncommon EGFR mutations. What about these? So these are the exon 20 insertions. And this is the next most common subgroup, about 10% or so of the ones we find. And there, we've got exon 19 deletions. They pull things into active formation. Exon 20 insertions, you could think of them as pushing things into active formation is how I think about it. They sit on each side of the active part of the protein. And Amivantamab, the drug I just talked about, combined with chemotherapy is actually our go-to standard there. And I'm happy to just talk about that more in the Q&A. But there are a lot of clinical trials ongoing trying to develop EGFR exon 20 active pills, because our current pill-based EGFR drugs just don't work well against this particular class of mutations. And those have shown some really promising data. So I think we're going to have these sort of agents available in the future. Then we have all the rest. We often call these the atypical EGFR mutations or the uncommon EGFR mutations. These are all really different, and they vary in their sensitivity to our current EGFR pills. For the most common of the uncommon mutations, afatinib actually is approved. It's a second generation EGFR pill that tends to bind to them a little better. But for some of them, off-label osimertinib might be used if we have some data that there's activity. Off-label Amivantamab plus Lazertinib, the combination I just talked about for common mutations, has also shown activity for a number of these. And there are also a lot of drugs in clinical trials trying to look at, can we design EGFR inhibitors that are better for these uncommon mutations by deliberately designing for them? And that also is something I'm always looking for patients.